Hello friends, I am Dr. Harsh Mathur from Om Netralay, Varanasi, India, and today we'll be discussing about how to do a mechanical chop with a 1.25 mm karate chopper in this soft gummy nuclei. The patient is 55 years old, diabetic. So let's see. With this MVR blade, two side ports are created as I'll be using a bimanual irrigation aspiration. A bit of phenocane is injected. The anterior capsule is stained with trypan blue dye underneath the air bubble. The dye is washed and the chamber is then maintained with 1.4% sodium hyaluronate. A triplanar incision is being constructed, and with this 2.8 mm steel keratome, the tunnel is fashioned. Now I am aiming to create about 5.5 mm of rhexis. So this flap is created with the help of this 26 gauge bent needle, and with the help of the utrata, the flap is then extended all around. So I have these utrata forceps where I have manually made marks at 2.5, 5 and 5.5, and this seems to be a 5.5 mm rhexis, good enough. Now hydrodissection, gentle wave is injected, the opposite pole is tapped, same is then repeated, and the nucleus rotates nicely. And now is the time to introduce the phaco probe. This is cataract 3 phaco machine. A lot of superficial cortex is there, which is aspirated nicely, but it's still there beneath the anterior capsular rim. So this can often misguide and judging the depth of the nuclei. Now this karate chopper goes to the far periphery and then brought towards the probe and laterally separated. After 2 attempts, I could get a reasonable crack, but not through and through. So I repeat it again. The nucleus is held by the probe and then crushed between the karate chopper and the phaco probe. So in these soft nuclei, the main challenge is to hold the nuclei. So I am just crushing the nucleus between the chopper and the probe. See again, it's crushed and then laterally separated. The trick is to go deep in the far periphery and then bring the chopper towards the probe, and it will crack the nucleus nicely. Now once as I am trying to bring this quadrant up, it's just eating it away, so I just nudge it with the help of the chopper and then it comes up. And once you get one quadrant up, dealing with the other quadrants is pretty easy. Now these two quadrants are not completely separated, so I'm trying to lift one part up, not happening, so I go to the other quadrant and with a bit of vacuum it flips over and then the nucleus disappears in no time. So minimal phaco energy is used in these mechanical chops. It's helpful for the protection of the endothelium as well and deals with the soft cataracts pretty nicely. But in future I am planning to try these mechanical chops with a longer chopper. I'll be sharing those videos as well. So the advantages with these long choppers, at least 2 mm, is that you don't have to go too deep in the periphery to get the complete hold of the nucleus. as I had to do in this 1.25 mm chopper. Now the capsule is nicely polished. The bag is filled with OVD. And the IOL is injected in the bag. The leading haptic goes in the bag. It's a hydrophilic IOL. The patient is turning the chin downwards. That is why the eye is closer to the speculum at the upper end. But despite counseling, the eye was turned up. So now I have turned the chin up, and see, you can now see that the eye is in the primary position again. Now going beneath the IOL and washing off the OVD nicely to avoid any post-op intraocular spikes. The OVD is nicely washed off and the wounds are hydrated. So do let me know your thought process when you are doing a mechanical chop. Do you prefer a short chopper or a long chopper? And do you perform these chops in all your grades of cataracts, or you prefer it in soft cataracts? That's it. Now the main wound is hydrated. The anterior capsule is nicely covering the optic. So the stability of the optic in the long run will be very nice. Do like and subscribe to my YouTube channel and help it grow. I hope you like this video. Thanks for watching.